about PDA. So, am I audible properly and the slide is visible?
Yeah,
Yes,
lovely.
yes.
So, without much delay, I think we'll start with cyanotic congenital heart disease, and then in this cyanotic congenital heart disease, I think we'll discuss only tetralogy, as we have seen the classification of congenital heart disease, acyanotic and cyanotic. And in the cyanotic, we have seen multiple T kind of as a student, you have to remember to enumerate the cyanotic congenital heart disease is like tetralogy of Fallot's, TAPVC, TGA, tricuspid atresia, and truncus arteriosus. So these are the cyanotic congenital heart disease. So starting with some of the history part, because when we are discussing tetralogy, it is one of the oldest congenital heart disease diagnosed, and then uh, congenital heart surgical things also is been started with this disease. So in 1888, a name Fallot has described this as a blue malady, but he has not described this term of tetralogy of Fallot's. In spite, the pediatric cardiologist from Canada, Maud Abbott, has coined the term of tetralogy of Fallot in the honor of Fallot's in 1924. And according to one Prague, this is only a single abnormalities leads to a multiple problem. That we'll discuss in the further slide about this. This slide is very important for all of us when we are practicing in pediatric cardiac, because that has changed the treatment aspect of pediatric cardiac surgery, and as well as anesthesia also with this. So it is initially the tetralogy is labeled as blue baby, and with a lot of research of pediatric cardiologists, Dr. Helen Tossing and the surgeon Alfred Blalock, they keep on discussing in their lab in the presence of Dr. Vivian Thomas. He was assistant with Dr. Alfred Blalock. And in November 29, 1944, under the guidance of Dr. Vivian Thomas, Dr. Alfred Blalock has performed a surgery where they attached pulmonary artery directly to the one of the branch of subclavian artery, and then there will be a shunting of a blood happening from the systemic circuits to the pulmonary circuits, improve the blood, improve the oxygenation, and this has been performed on a child named Ellen Sensor. So tetralogy has been performed and known about tetralogy since last 300 years, and then very well-known name of Fallot's, Helen Tossing, and it has been described on Dental Police 50th anniversary in this paper. They describe the 300 years of tetralogy of Fallot's and what they divided into the era of pediatric cardiac specialty. The first era was before 1940, where the only diagnosis was happening, and then there was no treatment for congenital heart disease. So it is called as era of pathological anatomy. The second era came 1940 to 1970, where they started having a treatment. One of the treatment is BTs, and then later on there are multiple kind of surgical options available for this. It's called as clinicopathology and surgery until 1970s, and after 17 to 1990, the era where the surgeon has the confidence of operating in infants, and the cardiologist also improving in the diagnosis. The anesthesia, perfusion, and intensive care area also has been developed, and that is where the results become better in this era. And then we come to a current era where we are much more concentrating on quality of life and results oriented pediatric cardiac surgery. So this is how the history goes. Coming to the problem of tetralogy, it is labeled as fatal four of Fallots. There are four problems, but most of the cardiologists and specialists now understand that this is started with one problem and then it leads to other problems. So I'll go with the reverse of saying that what are the problem of Fallots. There are four problems. starting with overriding of aorta. When there is a overriding of aorta and malposition of interventricular septum leads to unrestrictive VST, which is present in outlet VST in tetralogy. With this malaligned interventricular septum or overriding of aorta leads to a right ventricular outflow tract obstruction. And because of a right ventricular outflow tract obstruction, RV has to pump against severe obstruction leads to RV hypertrophy. So these are the four problem in tetralogy of Fallot's: RVH, RV outflow obstruction, non-restrictive VSTs, and overriding of aorta. The prevalence of this disease is TOF is most common cyanotic congenital heart disease, and prevalence approximately 3 to 4% per 10,000 live birth. It is associated with many other syndromic association. The most common is 22q11 microdeletion and trisomy 21. There are additional genes been found associated with TOF, named JAG1, NKX2.5, GATA4, which is no need to remember at the student level and MD exam. They will not going to ask detail of about this, but this is fine, better to remember. As we are discussing about tetralogy, the problem start with a single problem and leads to other. That is what it is called as monology of stem cells, which we are describing in first slide. So because the basic pathology results from underdevelopment of RV infundibulum, which leads to anterior malalignment of infundibular septum, leave behind the large unrestrictive VSTs. And because of anterior malalignment, there will be a various degree of RVOT obstruction, starting from entirely atretic TOF pulmonary atresia, or severe RVOT obstruction, or there will be a mild RVOT obstruction, and depending on that, there will be right ventricular hypertrophy. So that is why it is called as monology of stem cells or monology for tetralogy. The association of tetralogy, it is been associated with right aortic arch around 25%. There will be coronary abnormalities of almost approximately in 10% of the cases. There will be presence of PDA. If it is present of ASD, it is called as pantology of or something, or it will be present with multiple VSTs, and also it is associated with AV septal defect also. So notably, there are a lot of problems regarding the coronary, and then one has to be kind of in diagnosis, give a particularly fact that coronary crossing RVOT or not, because it changes the overall treatment and management. So this is how TOF associated with multiple other problems. Coming to the one of the very basic and problem with the tetralogy is hypoxic spell. And more as a student, either in MD or cardiac anesthesia, you have to know in and out about this, because it comes in a short questions or it comes in a viva or a table. So that is very important for all the students who is attending this. So it is called as hypoxic spell, or also it is called as TET spell, or also it is called as cyanotic spell. It characterized by four problems. Start with paroxysmal of hyperapnea, where rapid and deep respiration the child will be having, irritability and prolonged crying. It leads to increased cyanosis, and because there is hardly any flow going from the RVOT, there will be decrease in intensity of murmur in the pulmonary area. These are the four components will be diagnosed as a hypoxic spell. The spell can be very severe also. It may lead to limpness, convulsion, cerebrovascular accident, and sometimes death. So one has to be very careful, and if necessary, treat as early as possible and aggressively. It occurs in young infant, and the peak incidence will be between 2 to 4 months or 2 to 6 months. And hypoxic spell require a timely recognition and prompt appropriation of the treatment. The pathophysiology of hypoxic spell will be, so because there is in a tetralogy, there will be RV and we will have a large VST. It will be acting like a single pumping chamber, and there will be equalization of pressure of RV and LV. If there is a lowering of SVR or increasing the resistance across the RVOT will lead to right to left shunting. In this stimulate the respiratory center and produce hyperapnea. Hyperapnea results in increase in the systemic vascular resistance, which in turn increase the right to left shunt through the VSTs, and there is obstruction of RVOT that's lead to a vicious cycle. So what will be the treatment option for this is, let me start with the mechanism again. So because of a reduced SVR, either it is because of a vasodilating drugs, sepsis or injections, environmental factors, leads to increased right to left shunting across the VST, or if it is because of an infundibular spasm, either because of a pain, continuous crying, beta agonist, will lead to increased right to left shunt. Because right to left shunt increases, there is an increase in the hypoxia, will lead to acidosis and a rise in the PaCO2, which ultimately leads to increase in the pulmonary vascular resistance. Because of a high PVR, again the right to left shunt increases, and because of a high PVR, there will be increased PaCO2, and respiratory efforts will be increased because of to compensate high PaCO2, which will lead to increased systemic vascular resistance. This become vicious cycle, and one has to break this cycle to treat the hypoxic spell. So what are the treatment options for hypoxic spell? Obviously, as I mentioned, the aim is to break the cycle. If the child comes in either in OPD or in the ICU, one can start with the knee chest position. How the knee chest position will help? It will increase the systemic vascular resistance, which will lead to reduce the right to left shunt and break the cycle. Second is, child will be very irritable, so one has to give a sedation to the child. The drug of choice for sedation will be morphine 0.1 to 0.2 milligram per kg subcut, or IM, which will suppress the respiratory cycles and abolish the hyperapnea. The third option is to optimize the preload. So if a child comes, one has to give volume boluses in the aliquot of 5 to 10 ml per kg, normal saline. The fourth problem will be to treat acidosis, and to treat this, one can give soda bicarb 1 milliequivalent per kg, roughly. Or if you are having in the ICU, if you are having some lines, or if you already put a peripheral venous line and then send a sample, treat accordingly when we are receiving the gas. This will reduce the respiratory center stimulating effects of acidosis. Many of the book has mentioned about giving oxygen, which will reduce the pulmonary vascular resistance. But because if you are unable to break the cycle, there will be hardly any blood going to the pulmonary circuits. Giving oxygen is a limited value here. The other part of treatment is use of pharmacological agents like ketamine to sedate the child and to calm the child, 1 to 3 milligram per kg. Average dose is 1 to 2 milligram per kg, slow IV, which will increase the SVR and sedate the child. To reduce the heart rate, the drug of choice is propranolol 0.01 to 0.2 milligram per kg, slow IV, and sometime if needed, infusion can also be started. And in a boluses of alpha agonist, phenylephrine can be used in the dose of 2 to 10 mics per kg, bolus doses. Sometime even infusion also can be started if there is a prolonged TET spell. So this is how, in a short summary, managing the hypoxic spell. Oxygenation is still, in my opinion, is doubtful, will not help much. By increasing the SVR is one of the important aspects. Abolishing hyperapnea by sedating the kids. Fentanyl is not very familiar to use because it is very potent and not a cardiostable drug. That is why morphine rated higher than fentanyl, and obviously correction of acidosis. Coming to the hemodynamics of TOF, there are two variants. One is pink TOF and blue TOF, and that depends on the degree of pulmonary stenosis. So how the blood circulate when there is a tetralogy of Fallot. As I mentioned, there is a large unrestricted VST. So the inferior and superior vena cava blood reaches to the RA, which is deoxygenated blood, going to the RV. From the RV, because there is a severe RVOT obstruction, some amount of blood going to the pulmonary circuits, and rest of the blood mixing directly to the LV, which make the LV blood also deoxygenated. And because there's only some amount of blood going to the pulmonary circuit, that only the either 1/3 or half of the blood going to the reaching to the pulmonary circuit will be oxygenated and come back to the LA. So there will be from the LV, there is a two from the LA blood which is oxygenated and the RV which is deoxygenated blood mixing here and pumping to the aorta. So that is why aortic blood will be lower saturation depending on the severity of RVOT obstruction. So this is how the top will present. Either it is present as a pink top where there is a 100% saturation. The other extremity will be the severe cyanotic. And as I mentioned, that is depend on the severity of RVOT obstruction. So if a pink tetralogy presents, there will not be any, not much RVOTO, and it will behave like a VST with a left to right shunt. Then the mid segment, which is blue top, where the classic top, the degree of RVOT and override depends on the saturation of this baby, and profound tetralogy where severe RVOT O will be there and the saturation will be very low. So these are the three variant of a tetralogy which will present to one of the physicians or cardiologists. The sign and symptoms of tetralogy will be the child will have a cyanosis, and cyanosis depends on degree of mixing of RV blood to the LV, which lead to the reduction in oxygen saturations. So that is depend on the obstruction of RVOT. Irritability, child will be irritable because of hypoxia and because of continuous kind of lower saturations. So if a child comes with a fever, one can think about having infection. Because it is low pulmonary blood scenario, there will not be much respiratory problem or respiratory infections. So if a child comes with a fever, one can think about these are the patients come with a very high hemoglobin, and because of that there will be abscess in the brain, and one should rule out if a child comes with a fever. So one is brain abscess, second is infective endocarditis, and third, if a child with have a tetralogy with multiple MAPCAs, it becomes high pulmonary blood flow. These are the three conditions child will come with a fever. Spatting episode is there or not, one should ask while taking the history of tetralogy, because that will help in knowing about the severity of the disease. If a child come with a conversion that suggests that this child was having a CNS problem associated with tetralogy of Fallot's, and child may come with a CCF. Rarely, as I mentioned, on a few of the like pink top can come with a presentation come with a CCF, or TOF associated with multiple MAPCAs can present with the CCF. So these are the symptoms of tetralogy presentation. Coming to the examination of tetralogy, obviously there will be a varies of cyanosis depending on the, as I mentioned, depending on the RVOT obstruction and mixing of RV and LV blood. Because of a cyanosis, there will be clubbing also present. Gingival hyperplasia usually present in a later age group of presentation, and there can be infective, there can be endocarditis also. On auscultation of tetralogy, there will be a loud, rough, spindle-shaped systolic murmur, which is a murmur of RVOT. The flow of blood going from the very narrow RVOT create this kind of a murmur, which is loud murmur. And as I mentioned, when there is a tetralogy of when there is a TET spell, because there is hardly any blood passing from this RVOT, the murmur either disappear or reduced. And during the treatment, if a murmur reappear, that suggests that TET spell is improving. So VST, because it is large unrestrictive VST, it will not cause any murmur. But very rarely in a tetralogy, the VST can be restrictive also. And second heart sound will be soft and single, because doming pulmonary valve or pulmonary valve will not be a normal, and that is why it is not creating much sound, and that is why it is mentioned it is single and soft. Coming to the ECG of tetralogy of Fallot's, there will be a right axis deviation because there is a RVH. The right waves in the right precordium V1 and V2 will be tall, and deep S wave in V5 and V6. If there is a left axis deviation in tetralogy ECG, one should suspect about AV canal associated with tetralogy. That is one of the very important ECG finding to diagnose TOF with AV canal. Coming to the chest X-ray, which is very typical chest X-ray, it is called as boot safe heart. And why it become boot safe heart is because there is a decreased pulmonary blood flow, so there will be less vascular marking on the chest X-ray. The RV hypertrophy will be there, so there will be upturn of apex, which is called as RV type of apex, and there will be low pulmonary blood flow going to the pulmonary circuits, and that is why the pulmonary conus will be concave, and this is how it become boot safe heart. So echocardiography, one should diagnose whether there is a situs solitis or situs inversus. VSD can be described as either it is single VSD. If it is multiple VSD, has to be mentioned. Size and location, usually it will be outlet VSD and large VSD, but one should mention about that, and comment about rootability and overriding of aorta. So one was we are not performing echo pre-operatively, but if a cardiologist is coming or a case file come with echocardiography, one should note down all the points, because all these points are very important in managing the tetralogy of Fallot's. So VSD description has to be include single, multiple, size, location, rootability, and overriding of aorta. Overriding of aorta, if it is 100% override or 200% override, it become DOR with top. So that is why it is important how much overriding will be there. RVOT, degree of RVOT stenosis, either it is valvular pulmonary stenosis, subvalvular, or supravalvular. Comment about the pulmonary valve, Z score. That Z score is a score where they have measured the 100 or 200 hundreds. It goes in multiples of hundreds, and then they come with a normal scoring system where normal population, how much will be the pulmonary valve, and then it kind of correlate with abnormal valve. If Z score is more than -2, suggests the pulmonary valve is very small, which will later on cannot be salvaged, and one need to during the surgery, the surgeon will cut across the pulmonary valve and put transcerebral patch. So annular size is important, and Z score is important, and the pulmonary artery visit, the size of LPA, RPA, MPA, because that will suggest about surgical repair. Coronary crossing RVOT is very important because that will change the treatment and management. If it is large coronary crossing RVOT, surgeon cannot resect the RVOT which is narrow, then there will be alternate surgeries available or palliative surgeries available for this. That is why it is important. Collaterals, AP collaterals, aortopulmonary collaterals has to be mentioned in echocardiography if they are able to see it. And AV valve, it is sometimes associated with AV septal defects. So how is the AV atrioventricular valve, mitral and tricuspid, and is there a regurgitation or not? That is just one slide about TEE in tetralogy. But because this presentation is very basic, I'm not going to go into the detail of description of this. But this is how the overriding. This is the interventricular septum. This is the aorta. Here is the aorta. Ideally, the septum should go like this. But because it is anteriorly malaligned interventricular septum, it is crossing like this and leaving behind large VST, which is this is left ventricle, this is right ventricle. So blood is passing from the right ventricle to the left ventricle, which is why that is a red flow here. And this describe all the component of tetralogy of Fallot's. Anterior division of interventricular septum, large unrestricted VSTs, hypertrophied right ventricle, and overriding of aorta. And during the performing TEE, one can measure the gradient across the RVOT, which is aligned pulse wave Doppler here, and then one can get such kind of gradient, which is 30 mg here. So this is how there are many other images and all these things required during TE, but we are not going to go into the detail of TE here. To complete the diagnosis, sometime it is required, apart from echocardiography, CT scan, MRI, or cardiac catheterization, especially in tetralogy of Fallot's. So what benefit we are getting when performing CT scan, or what information we want from CT scan when we are performing in tetralogy of Fallot's about major aortopulmonary collaterals, so MAPCAs. We should know about is there a MEPCAS present or not, because that will change the treatment and management. We should know about the branch pulmonary arteries. If it is small stenos, individual branch pulmonary arteries, small individual branch pulmonary arteries absent. These are all varieties will be present during tetralogy of Fallot's. Coronary abnormalities, as I already mentioned. Is there any associated airway abnormalities can be detected during the CT scan? Lung problem, if it is there, one of the lung is hypoplastic, not hypoplastic, and etc. And one can able to see the rootability of VST also in CT scan. As I mentioned, diagnostic cath is one of the gold standard in initial era when the echocardiography was not so accurate, especially in tetralogy. But nowadays, the echocardiography is not become compulsion, but some of the cases, most of the unit perform diagnostic catheterization for tetralogy of Fallot's to know the anatomy of RVOT. They'll do a pressure study to see about end-diastolic pressures and volume of both the ventricle to treat appropriately. And if it is MEPCA seen in CT scan, it is better to delineate MEPCAs during the catheterization. And what we want to know, how many MEPCAs are there, the type of MEPCAs, the MEPCAs is stenos or not, the MEPCAs is hypertensive or not, is there any dual supply or not, and then if require dual supply is there, then they will do a coil embolization of a MEPCAs during the diagnostic cat itself. So that is what is coil embolization of MEPCAs if it is dual supply to the lung. Branch pulmonary artery size and stenosis is important. Additional VST is present or not, and coronary crossing RVOT or not. So these are the information we want from the diagnostic care. And I am not going to go into the detail of MEPCA's classification because it is out of your syllabus, but it can be a three major aortopulmonary collaterals. One is directly going to the pulmonary circuits, one is going to the branch, and one is not matching only. So these are the three variant of MEPCAs. We'll not go into the much detail about that, but important for all the students will be this Magoon and Nagata index, and the last one is total neopulmonary artery index. So what is these two are very important. One is Magoon index, that is called as diameter of RPA plus diameter of LPA divided by descending aorta. So blood in a human heart, the blood goes from the blood circulate in a series. It is not in parallel. So RA blood, the same amount of blood going to the RV, same amount of blood going to the pulmonary circuit, come back to the LA and LV to the aorta. So that is why two branch pulmonary artery, RP and LPA diameter plus divided by descending aorta should be around 2 to 2.1, which is normal. If it is more than 1.2, it is adequate to close a VST and to give a total correction. But if it is less than 0.8, the surgeon should not close the VST because the branch PA is very small, and after closing the VST, the this branch PA and RV will not take full load of total cardiac output, and that is why total correction will not be possible if it is less than 0.8. The second index is Nakata index, which is also a kind of same what the Magoon ratio is there. Nakata index is cross section of RPA plus cross section of LPA divided by body surface area. Same RP and LPA size we want to know and divided by body surface area. Here the normal value is 200. Here it was 2. Here it is 200. More than 150 is fine. One can perform total correction. But and more than 100 is fine for two ventricle repair. Here also at 1.2. So it is roughly 100 and 200. But if it is less than 100, again, it is not fit for total correction. And the third one is total neopulmonary artery index, which is not usually asked during MD exam. But just to complete the list, it is AP collateral index plus Nakata index. and there are multiple MEPCAs is there. So sum of the MEPCAs total divided by body surface area, more than 250 is suitable for repair. There are three treatment options for tetralogy of phalanx. One is medical management, the other is palliative surgery, and third is total intracardiac repair or ICR. So medical management, if a child come with 3 months or 4 months, usually most of the center in India, not much cyanotic history of not much cyanotic spell, then they go for regular follow-up, monthly or maybe 15 days, depending on the symptoms. Try to wait for 6 to 9 months here. It is important. We'll come discuss later about why to 6 to 9 months. But many of the Western world, they operate early, even 2 months and 3 months for total correction. But still in India, because of the results and all, still people or many of the center wait for around 6 months. Child will be on beta blocker to prevent TET spell and prolong the follow-up as long as possible. One should keep having a history of spell, weight gain, hemoglobin, and cyanosis, and keep having a check on infection. So these are all the medical management follow-up. Coming to the palliative surgery, the option for palliative surgery will be either is modified BT-shunt, which is the initial BT-shunt was directly the subclavian and pulmonary artery was attached directly, but later on it become modified when they are started using Gottes graft. So that is what is modified BT-shunt. Cyano-shunt is the shunt directly placed on the RV and directly RV to PA to RV to PA shunt, which will eliminate the RVOT obstruction and directly supplying the blood to the pulmonary circuit. It is called as cyano-shunt. Central shunt is performed when there is a very small branch P and then they directly attach graft between MP and aorta to have a better flow in the shunt. That is called a central shunt. Some of the unit, they perform transannular patch. They just cut across the RVOT and do a pleoplasty plus or minus without doing this kind of a shunt. Also one of the treatment option. A shunt can be done on either on bypass, off bypass. There are multiple discussion about that, but no need to go into the detail. Just to know that BT shunt can be performed off bypass and on bypass also, and BT shunt can be performed thoracotomy and midline. These are having different indication as well as advantage and disadvantage, but not going into the detail here. And the other palliative option will be the cath procedure. Nowadays, the cardiologists are bold enough to put RVOT stent rather than going for transfemoral patch and BT shunt. Or sometimes it is very small kid and there is a PDA open, they can do a PDA stenting also. If there is a very tight RVOT obstruction or top with a pulmonary atresia with a duct dependent circulation, they will perform PDA stenting. So this is the one of the case where we have performed RVOT stent in tetralogy. This is a severe RVOT obstruction, hardly any blood flowing from the RVOT. They put balloon, dilate it, and then they put a RVOT stent. So RVOT stent will be in this direction along the RVOT. And this is a case of PDA stent we have performed in one of the neonate where top pulmonary atresia was there. We have cut down the carotid and gone through the carotid to perform very easily. This is the stent what they have placed in the PDA, and the stent will be in this direction because it is in PDA stent. This is our left IJV because they have used carotid cut down here. So we have put a left IJV and child was intubated because it was a neonatal surgery. So this is what the cath procedure can be performed. When we should palliate this kind of a tetralogy, or what are the indication to do a palliative surgery rather than going for a total correction? So if age is or weight is low, one should go for palliative procedure. If branch P are not adequate, just do a BT shunt or cyano-shunt. Let the branch P grow adequately and then perform the total correction. If a child is very cyanotic, one should go for palliative surgery. It is just an example of yesterday's. We received a case of tetralogy with pulmonary atresia. Child was not tetralogy with severe RVOT. Yesterday only we received in our ICU. Child saturation was hardly 10-20, lactate was rising. We took to the yesterday midnight to the cath lab, put RVOT stent. Now the child is stable. So that is what is. Child comes with very cyanosis. Immediately the cardiologist can put a stent there and then stabilize the patient. If a child is having sepsis or other comorbidity, rather than putting on a pump and spreading the infection, one can do a off pump BT shunt and wait for the sepsis and other things to be under control. If there is a coronary crossing RVOT, let the modified BT shunt can be performed, and later on we can use a conduit to overcome this problem as a total correction. And TOF with the pulmonary atresia, better to have early presentation, better to have a palliative procedure. These are the three options which I have already discussed, that TOF come if there is option of RVOT stenting, palliative procedure, or complete repair. There are a lot of literature about performing BT shunt, and then as I mentioned about few of the things, we will not go into the detail of all this slide because this is not for a purpose for the students. But gradually the indication to perform palliative surgery is reducing only in the presence of coronary abnormalities, presence of multiple VST. Some of the center are performing it. But some of the good center are mentioning about they have abundance of performing BT shunt, and they perform total correction at whatever the age group is. As I mentioned in my previous slide, that in India, many of the centers still wait to around 6 to 9 months. But this paper from SickKids Canada, they mentioned that they have not done this, and then they presented their reports. And I'm not going to go into the detail about that, about how their results are. But and then why people are still not very happy of performing palliative procedure in a small age group is this paper from AIMS Institute. They concluded if they perform BT shunt in neonatal age group, the risk and morbidity is significantly high. So one has to be careful. It is easy surgery, but not easy to manage in the ICU, and having higher mortality, especially in neonates. What we follow in our unit is palliative procedures for tetralogy will be if a child present less than 6 months, major coronary crossing RVOT, multiple VST is there, branch pulmonary artery is not good, very cyanotic kid, and child comes with the multiple MEPCAs, unifocluxin shunt will perform. This is how we are having our own indication of performing this. Intraoperative management for any of the tetralogy, especially when we are taking about 6 months, 10 months of old child. Hello. One has to be very careful about keeping this patient's NBM, and that is why preoperative hybridization or NPM status should be shortest as possible, and preoperative IV fluid should be compulsory, especially when you are dealing with tetralogy. We are usually giving sedation in the recovery room, especially in the kid where it is difficult to separate from the parents, and this will definitely avoid of triggering TET spell. So sedation is required, either it is oral, nasal, IV, but some kind of a sedation is needed when you are dealing with 1 or 2 year old kid and taking to the theater. We are using ketamine and midazolam in recovery because we are having IV line in most of the cases. IV induction is preferred over inhalation because of there is a low pulmonary blood flow, and in the tetralogy, one has to secure central venous line and arterial line. We are putting all the lines after intubations, and we preferred femoral arterial line when we are dealing with sick subset, severe cyanotic TOF, or when in a palliative procedure also we preferred femoral arterial line because of post-operative problems. Spell management, as we already discussed, and use of dexmedetomidine infusion to prevent tachyarrhythmias and give sedation and analgesia. So we are starting in almost all cases dexmedetomidine infusion for tetralogy of repair. Because this patient is having severely cyanotic, there will be platelet dysfunction to start with, there will be low fibrinogen level to start with, and that is why this patient will have a deranged coagulation. So adequate blood and blood products should be available when we are performing such kind of patients. And phlebotomy, pre-op phlebotomy is not very kind of familiar now. It's a questionable rule because if hemoglobin is more than 20, still some unit believe that do a pre-op phlebotomy and then perform surgery. We are not doing this because it is not having any advantage. The role of tranexamic acid, we are using tranexamic acid if hemoglobin to start with more than 15 milligram per deciliter. T and peri and post-operative is very important when we are performing such kind of surgery. Management of TOF, so perioperative management of TOF, very in short, the shunt, BT shunt, the flow depends on size of a shunt, proximity of the aorta. As I mentioned, central shunt is having higher flow, size of a branch pulmonary artery, length of a graft, lie of a graft. It depends on pulmonary vascular resistance and systemic vascular resistance, as well as PO2 and PCO2 and temperature. If someone is dealing of BT shunt in ICU, the target saturation around 65 to 75 because that comes around cubic use of 1. The underflowing shunt diagnosis will be the cubic use is less than 0.7 or saturation goes below 60%. In these cases, one can increase the FiO2, adequate tidal volume, give optimal preload, mild hypocapnia, increase respiratory rate, optimal PEEP, and rule out lung collapse collections and all these things. Perform echo to check there is a mechanical problem of shunt. Start heparin if it is there is stasis of blood, and give volume bolus and try to optimize the saturation. If there is a higher flow shunt, one can reduce FiO2, smaller tidal volume. Mild hypercapnia will increase the PVR, will reduce the shunt flow across BT shunt. High PEEP will be helpful, but not more than 7 to 8 PEEP. And continue mechanical ventilation till you control the flow of a shunt. The last part of the presentation will be TOF coming with total correction. Just to highlight you that when we are discussing about total correction, actually it is not total correction because we are leaving behind many of the problem of pathology intracardiac repair, because we leave behind most of the cases right bundle branch block. We leave behind some degree of pulmonary regurgitations. There will be long or there will be patch in the infundibulum which is non-contractile. All this will lead to problem of chronic RV volume overload, ventricular disc synchrony, will overall lead to right ventricular dysfunction, and this patient in long term may have a problem with RV dysfunction causing sustained VT, and some of the cases will have a death because of this. So that is why what I feel is the concept of total correction in pathology, it is misnomer. And we are treating one disease, but we are inducing another disease in tetralogy. And that is why one, if some relative is asking that if it is only one surgery, especially in tetralogy, one should not commit about saying that yes, it is only one surgery. It may require another surgery in future when we are doing a total correction of tetralogy surgery. When to do total correction, I'm not going to go into the detail of all these things, but if someone is asking in exam, the ideal even evidence-based, the ideal age to perform total correction is 3 to 11 months. And that is why I'm saying in India, many of the centers is still waiting around 6 months to 9 months to perform elective tetralogy corrections, total correction. Choice of inotrope, this is my choice, but this choice can be differed depending on the unit to unit and their protocol and policy. But usually what we do is, if child come with ICR with RVOT, only RVOT resection, usually in a more of a pink TOF, will be having a milrinone and dopamine plus calcium. If you are performing ICR with transdermal batch, which is much more cyanotic case, we require milrinone plus adrenaline rather than dopamine, because we want higher potent inotropic agent compared to dopamine. And obviously multiple blood products we are using for calcium infusion will be there. If child come with higher hematocrit preoperatively, sometimes we have to add noradrenaline, because suddenly we are hemodiluting this case when we are coming off pump, and to maintain the SVR, we need to add noradrenaline. In older kid also, we are using cut down on milrinone dose, and sometimes we may require noradrenaline in this case also. For the arrhythmias prevention, magnesium boluses while coming off bypass and dexamethasone infusion has helped to reduce the overall arrhythmias. For the coagulation management, FAP, platelet, cryo, and blood, tranexamic acid, and hemostasis is important. Coming to the other aspect of pathology correction, especially in when we are in the theater, many of the centers, most of the center put a needle in the RV and check about check about the pressure in RV and pressure in LV, and just a minute. So many of the units check about pressure in RV and pressure in LV, and depending on this pressure, one can decide about the repair is adequate or not. So PRV LV is a ratio which is, after tetralogy of correction, should be less than 0.7. If PRV LV is more than 0.7, one should find out what are the problems. The problem can be residual VST if it is significant or not. So one should check the echocardiography and rule out residual VST. The other thing is optimize the preload, and if it is because of a dynamic RVOT obstruction, and check again. If there is an anatomical obstruction in RVOT, one has to go back and repair this significant RVOT obstruction. And if it is the high PA pressure, and because of that there is a high PRV LV, then one can fenestrate the VST, or one can use pulmonary vasodilator to treat it. So the reason for RV dysfunction and LV dysfunction, especially when we are dealing with total correction, because there will be RV dysfunction of in a tetralogy. The reason are hypertrophied RV because of aortic cross clamp and long duration of aortic cross clamp. There is a discrete RVOT resection can lead to RV dysfunction. The large VST patch, which is non-contractile area of interventricular septum, leads to RV dysfunction. Paradoxical interventricular septal movement lead to RV dysfunction. Free PR will also lead to RV dysfunction. High PVR will lead to because of a CP effect will causes RV dysfunction. If there is a residual VSTs and residual TR will lead to RV dysfunction. And if there is a tachyarrhythmias, which will lead to RV dysfunction. The reason for RV dysfunction in tetralogy will be prolonged aortic cross clamp, large VST patch, paradoxical interventricular septal movement. Because of ventricular interdependency, severe RV dysfunction leads to LV dysfunction. Arrhythmias and preoperative underfilled LV will causes LV dysfunction postoperatively. Managing these patients post-operatively, I think we'll not go into the detail of much because that will not be your part of our discussion. So I'm skipping this slide and directly going to the last slide, which is top for non-cardiac surgery. So if a top patient comes for non-cardiac surgery, if it is unrepaired, then one has to go for a detailed echocardiography and find out the problem of how severe is the tetralogy. If it is very severe RVOT, then the risk increases. If pink top is there, then the risk will not be much. So check about coagulopathy also, check about spell history, check about preload SVR, and then think about regional block when you are going for unrepaired top for non-cardiac surgery. Repaired top in echocardiography, I think one should see about residual problem, free PR, ventricular functions, infective endocarditis prophylaxis. Is there any restenosis present after surgery or not? RVOT gradients and arrhythmias is there or not? After checking all these things, one can think about how high risk this non-cardiac surgery, and then give anesthesia accordingly. So this is how we complete our tetralogy discussion. So I think I am okay for any questions here.
Okay. Are there any questions anybody would like to ask? I wanted to know what was the dose of tranexamic acid that you use?
So, madam, in literature there are 3 doses. One is it is written about infusion dose. So 1 milligram per kg per hour is infusion dose, but we are not putting on infusion. So 10 milligram per kg before incision, 10 milligram per kg on pump, and 10 milligram per kg on protamine. higher dose of tranexamic acid. Some of the literature are mentioning about very high dose, 30 to 40. But higher dose of tranexamic acid is not should not be used because it is associated with convulsion and CNS problem.
Okay. And do we electively put some pacing wires in these patients if at all you find, even if you find them coming back and say sinus rhythm, would you like to electively put them?
Yes, madam. So what our unit policy is, whenever we are dealing with any VST, like tetralogy VST, simple VST, so on, and then all complex congenital on, we are minimal having one V wire and two A wire.
Okay.
Because of tetralogy, there are higher chances of tachyarrhythmias and going for jet. And while coming off also, when we are having some kind of tachyarrhythmias, we put all four wires, two V wire and two A wire, because later on in ICU, we might require to use quadron or reducing the rate and then start pacing. So it is very important to have a ventricular wire as well as atrial wire.
And there was a trend that when we were getting these patients off pump, we would give them a dose of milrinone and coming off, and then of course from our end we would start milrinone infusion as well. Do you yet continue that?
Yes, madam. So in all patient, when we are using milrinone, we are giving a bolus of milrinone after releasing of cross clamp on pump, which is 50 mics per kg dose. And then later on, after rewarming from 32 to 35, we start infusion of milrinone, which is minimal dose of 0.5 mics per kg per minute. And sometimes we increase if needed to 0.75 mics per kg per minute.
Thank you. I think there are two questions. One is Anish has asked, what is the dose of milrinone?
So as I mentioned, we are giving bolus of milrinone of 50 mics per kg on pump after releasing the cross clamp, and later on 0.5 mics per kg per minute. So 0.5 to 0.75 mics, but we are starting with 0.5 mics.
Is there any point of care way for you to check out the ionized calcium in these patients, or do you send it to the lab all the time?
So all our ABGs come with ionized calcium. So we will see the ionized calcium. It is routine policy in most of the cardiac unit that while coming off, they used to give some bolus of calcium before separating from the bypass. So we are also using some bolus of calcium. And then these are the patients, because we are going to use many of the blood products to control the coagulopathy, like blood and FFP. We usually start calcium infusion here.
Divya has two sets of questions. She's asked, what is given for pre-op sedation and how do you induce and sedate without following the hemodynamics and of course the saturation? And the next part of the question is, I believe she means MAPCAs, that if there is the prognosis better for the child?
So I will give this sedation answer first. So because our policy is to put a peripheral line in the ward, most of the kid comes with the peripheral line. So we like to give ketamine, usually 1 milligram per kg and 0.5 milligram per kg midazolam in the ICU OT recovery, and then only we save the patients. So because we are using ketamine, it maintains the SVR and that will not causing fall in blood pressure, and we are using small dose of midazolam. During induction, we are using again further bolus of ketamine plus midazolam and then small dose of opioids to prevent dead spell, and then short acting muscle relaxant and intubate the kid, and then we'll put an arterial line to monitor the blood pressure.
And she wants to know about the MAPCAs.
So MAPCAs, the prognosis, what she mentioned about prognosis with MAPCAs. So when there is a presence of MAPCAs and branch pulmonary arteries are very small, the native branch pulmonary arteries are very small. And even if you go to the further step, they are not confluent. These are the very horrible anatomy, we can say. Some of the cases, some of the time we are deferring the surgery if there is non-confluent branch, native branch pulmonary artery and very small pulmonary arteries. We are not giving good prognosis, and sometimes we are not even operating such kind of patient because prognosis wise they are not very good. Unifocalization can be done if it is good MAPCAs available. So unifocalize plus BT stent is a palliative stage 1, and then stage 2 closure of VST and RV to be a conduit. But they require multiple surgery, and the prognosis wise, presence of MAPCAs and a smaller branch pulmonary artery are a risk factor for bad prognosis. Vijay Setti is asking about rootability. My meaning of rootability is when we are asking for total correction, there is a large VST in tetralogy. For the total correction, the VST patch should be put in such a way that LV will route to the aorta and RV will go to the pulmonary arteries. But in a cases where 200% or 100% malaligned interventricular septum, it is called as DORV type of tetralogy. In those cases, both the outlet coming from RV and sometimes the VST patch cannot be route in a way that we will route RV to the PA and LV to the aorta. And those cases, we might require a different kind of a surgery rather than a simple VST patch and closing the VST.
Few doubts about yesterday. Please tell us about reactivity and reversibility in moderate to severe PH with oxygen and QPQS and cardiac work. Is it proportionally higher than whatever be the kind of shunt depends upon the QPQS?
So, madam, I'll start with the QPQS. What the QPQS means is in a normal heart, like without any intracardiac defect, QPQS is 1. As I mentioned, our heart work like a series. The same amount or quantum of blood from RA goes to the RV, goes to the pulmonary circuit, come back to the LA and LV. So one portion of a blood, the same portion of a blood reaches to the pulmonary circuit and come back to the systemic circuit. That is why it is called as QPQS 1. So normal QPQS is 1. Because of a large VST, there are additional flow from right ventricle going to the LV, and that is why the workload of a heart will increase and increase of pulmonary blood flow depending on the size of a VST. Because keep on the LV blood keep on mixing in the RV, and then additional volume of a RV keep on pushing to the pulmonary circuit. So suddenly, because of a VST, the pulmonary blood flow increases. How much it is increasing, that will calculate by QPQS. Like QPQS 2 means 2 times of blood going to the pulmonary circuits compared to the 1 portion of blood coming back to the systemic circuit. The higher amount of QPQS will obviously the heart has to work higher, because 2 times or 3 times blood has to be pushed from right ventricle to the pulmonary circuit, and that is why it is called, it gradually the heart will fail, and when we are getting a symptoms of congestive cardiac failure, which we calling is because of a large VST. The second part of a question is reversibility or reactivity. Because there is a very high pulmonary blood flow, there will be a severe pH. The normal pH will be around on resting to 24 mmHg, but because of very high blood flow going to the pulmonary circuit, obviously the pulmonary blood pressure will increase, which is called as pulmonary hypertension. The degree of hypertension decide about the quantum of blood going to the pulmonary circuits. Now, initially, when the child is in neonatal phase and gradually during the early age, there will not be any much changes in the pulmonary circuits. It is only a flow related severe pH, and flow related severe pH, as soon as we'll close a VST, the flow will come down, the pH will reverse back to near normal, and that is called as reversibility. Later part of a life, like if a kid comes with 5 years and large VST, because there is significant amount of blood going to the pulmonary circuits for 4 to 5 years, the changes happen in pulmonary circuit itself to reduce the flow in pulmonary circuits. So there will be pulmonary hyperplasia and pulmonary artery become aorta kind of a thickness. So they will try to prevent the flow. By doing so, there will be reversal of flow because pulmonary vascular resistance increases, and then there is a normal flow going to the pulmonary circuits, or sometime reversal of flow. That means the VST will start shunting later on right to left, causes Eisenmenger problem. So that is what is called as irreversible changes happen in pulmonary circuit. will be one of the indication not to operate or not fit to operate in such kind of patients.
What happens when there is a progressive, when I'm saying in an operated patient, say post 10, 12 years tetralogy coming back to you with progressive RV and LV dysfunction, and you cannot offer him much. Are these patients potential candidates to go ahead for a transplant?
So you are talking about unrepaired tetralogy or
repaired, but like it's almost 10, 12 years, and now you know they have been progressive ejection fraction has dropped, pulmonary RV hypertrophy is there, whatever is it.
Yes. Nowadays, because this patient will, as I mentioned in my presentation, that when we are telling it is total correction of tetralogy, it is not total correction. We are inducing another disease by either leaving behind free PR or conduit is there. The conduit will be stenosed later on. So nowadays, regular follow-up is required. And nowadays, in the place of RVOT, when there is a surgeon has put a RVOT patch or some conduit, early change of conduit by cath intervention or surgical intervention is indicated to prevent chronically RV dysfunction. But if somebody is not coming in follow-up and come with the later part of a life, there will be severe RV dysfunction lead to severe LV dysfunction, and these are the patient will be candidate for a heart transplant. Only thing is the risk factor for heart transplant, Dr. Vijay will be agree with me, because this patient has already received multiple blood transfusion and all these things. So their response and reactivity to the new organ will be very high. So it will be high risk on that aspect. Second high risk will be because it's a redo surgery. It is not easy to open the heart and put back the new heart. The risk increases. So obviously it will be a very high risk heart transplant, but can be done.
Dr. Kamlesh, we have with us Dr. Nayak, ex-HOD of neuroanesthesia from Nanavati Hospital with us. Ma'am, would you like to put any comments, madam?
Nice to hear your very lucid talk and excellent explanation, Dr. Tailor. It was a lovely lecture yesterday also, and today we enjoyed. And when I was listening to your lecture, I think I went back to cardiac surgery theater in Nayar with Alka Harde. I remember working. And I just want to ask you one thing. Is it nowadays the
17 kilometers wala ek bol.
Yeah.
Sorry, madam, I forgot your question.
See, we the neuroanaesthetists sometimes we get cerebral, abscess cases, no? But nowadays we don't see them much. Is it because of the good antibiotic therapy, or in municipal hospitals we used to see, but in corporate hospitals I don't see. Last 20 years only one I have done. So
yes, madam, I agree with you. Even last 12 years I am working in KDH. I have seen only 1 or 2 patients come for cerebral abscess, either for drainage or some kind of a CNS surgery in tetralogy. So there are 2 reasons, because now the awareness has definitely increased in India also. So there will be early pickup and then early diagnosis and then early surgery or appropriate time surgery. I think will reduce associated problem of tetralogy, which we used to see maybe in previous 20 years back.
What could be the whatever you said, totally correct. What could be the total lifespan of these patients? They can live normally, or somewhere I read it's the what would be the lifespan?
Yes, madam. So, like total correction tetralogy, they will be a near normal lifestyle, kind of a quality of life. Because nowadays we talk about because of so much improvement happening in pediatric cardiac surgery and anesthesia and ICU. We are not talking much about mortality because it is reducing now. So we are talking about more of a quality of life, and then this patient will have a good quality of life. But as I mentioned, it need to have a follow-up regularly, because they have associated problem when they grown up, and then gradually we are seeing more and more grown-up child with some problem, either it is arrhythmia or conduit related problems, or sometime problem with RVOT obstruction. But yes, they have a near normal life kind of quality of life compared to other complex congenital.
Last, I just interesting thing. So when I don't remember when I was in first MBBS last term or second MBBS first term, I had the wonderful experience of being with Dr. Helen Dossi. She had come here for International Cardiology Conference. So I was volunteer for that conference, So we had the opportunity to have tea with her at Hotel Ratraj and take her to Birla Matoshri Hall, where the inauguration was there. And so was with Christian Bernard. So I used to maintain a small, in students' days, I used to maintain a small booklet to collect all the autographs. So I had an autograph of Helen Tossi and Christian Bernard and Denton Cooley, because I had attended a workshop at British Candy Hospital in 1981, and my most favorite author, Dr. Lawrence Pharmacology. It was my Bible for pharmacology, my most favorite subject in medical college. If I get that, I don't know where I have placed it, but I'll search. If I get it, those autograph things, I will put it on the group. And
sure, madam, sure. Because you are very fortunate that you have kind of worked and met all those big names in the pediatric cardiac. And then if you're having such kind of, I think, document, please share it with us. It will be very precious.
Thanks a lot. Very, very nice lecture. Lovely lecture. Thanks.
Thank you, madam. Thank you.
Dr. Kamlesh, we have Dr. Dhaigude madam also with us. She's a pediatric anesthesiologist, very, very senior. Madam, any comments, please?
Yes, you have explained the situation very well, all different types of circulations and shunting and everything, pressures and all types of defects, different types of defects in POF. I remember we had done few cases. Actually, one question I would like to ask.
Yes, madam.
When we have a congenital anomaly like imperforate anus, or ideal atresia, those have to be operated immediately. I mean, I had done a couple of cases earlier. First and second day, they behave much about normal. I mean, of course, we had taken care of those days. We didn't have any arterial lines and even saturation probes and all that. So we just had to have our stethoscope. This is, I'm talking about 30, 40 years back. So they did behave okay. I mean, we could manage the surgery without any problem. Of course, with regional block and, ketamine was available. So we had used that. So what would you say? On first and second day, usually they behave okay. I mean, tough. Huh? In fact, you may not be able to hear the murmur also very well. So what is the reason for this?
So, madam, I think you must be mentioning about they present maybe 6 months or 9 months, or they present in neonatal age group.
No, neonatal age group.
Because
so first and second day, because these surgeries have to be done on first or second day.
So usual talk presentation also, they because in India we don't have much fetal echocardiography, so on prenatal diagnosis of TOF is not very common here. So our OPD presentation of pathology will be late around 3 months to 6 months when the PVR fall. Because of a fall in PVR, the RVOT gradient start increasing. And when increasing the RVOT gradient, they will be having a start shunting the VST right to left. And VST starts shunting right to left, they will obviously see the cyanosis from 3 months, 4 months, on 5 months onwards. And that is why the usual presentation of TOF will be around 3 months to 6 months, unless it is TOF with pulmonary atresia. So these are the patients when we are performing surgery, they are in good phase of anatomy and physiology. Because of a neonatal PVR, there will not be much gradient across the pulmonary wall, to start with, and that is why they behave like a VST, simple VST. And that is why it is easy to manage such kind of patients for first 3 months of life, rather than later part of life, when there is a symptoms aggravates and problem start seeing it.
I think the pressure differences and all those things go
Yes.
on
Increasing once the PVR
Yes.
start falling down, because of a neonatal PVR gradually comes down from 2 months and 3 months, it becomes normal, and then gradient increase from the RVOT because of that.
In fact, those days there were no pediatric cardiac surgeons in Mumbai. So a couple of patients we had sent them to Chennai or Bangalore.
Mhm.
You know, initially we had done a colostomy for imperforate anus and things like that, and then sent for the total repair, and then they came back for, you know, a revision of, you know, total correction.
But that is what, madam, that you able to perform this kind of a surgery successfully. It is not very easy surgery. On top of that, it is uncorrected lesion, and the era was also different. Not very much gazette available with us. It is really commendable to kind of listening that you perform, and then the child went to for the total correction and come back. So really, it is great.
Once I had noticed a TED spell on the table. That child, we had done a colostomy, and then he came for total repair. You know, colostomy closure, and yes, reanastomosis and all that. But that time, immediately after induction, of course, I had used ketamine, but immediately after induction, the patient went into TED spell. And as you said, we gave the knee chest position and gave fluid bolus and all that. We brought the child out. And then that time we didn't have a pediatric surgeon here, a cardiac surgeon. So we told the surgeon, I think the child will need a correction. And then the child had gone to other city, I think Chennai or Bangalore somewhere, got the TOF corrected, and then came back for a proper repair.
Yes, madam. Honestly speaking, what my view on this is, to perform non-cardiac surgery for pediatric cardiac patients are much more challenging compared to what we perform pediatric cardiac surgery. Because when we take a child for some correction or some improvement. So as soon as we induce, and after half an hour, child will go on bypass, and then we'll have a corrected circulation to start with. Because you're performing non-cardiac surgery, you have to deal with this problem of unrepaired lesion throughout your anesthesia, and maintaining this anesthesia is not easy compared to what we do in pediatric cardiac surgery. So it is difficult to do non-cardiac surgery in pediatric cardiac patient compared to pediatric cardiac surgery and anesthesia.
Your presentation was wonderful, excellent slides, and we're absolutely self-explanatory. Very good slides.
Thank you, madam.
Halbe, madam.
Hi.
Welcome, madam.
Yeah, I'm listening. It's a really very, very nice lecture. As madam said, excellent presentation, and the slides were very impressive. I just wanted to say how I used to, when I was at Nair lecturer, we used to do one PU valves with large VSD, and this boy used to sometimes behave like a VSD, sometimes we used to behave like a cyanotic this thing. And we used to manage only with caudal, caudal, and all they say, what else to do? Nothing was there. I had only halothane with me. Okay, and in the relaxant we had, like if we are lucky, we used to get Pavlon, otherwise DTC. What to use? So caudal was good, and really whenever he used to behave like a cyanotic, literally I say, I mean, now I'm going to get heart attack, that way. But he did quite well, and we send him for a total correction. But I think he developed some complication and I couldn't make it. I think the child couldn't make it. But one uncorrected child who was abandoned by the parents and was in the pediatric ward in Nair, uncorrected fellows, and still 9-10 years, the child was still alive,
Mhm.
with all toes and this, like we used to always call for exam, pulmonary osteoarthropathy to show that. But that child had survived. So there must be something which keeps the child this thing, is to play and all that, and but
Mhm.
still alive. So surprising. There must be some other mechanism was keeping the child alive.
Yeah, so gradually this kind of patient gradually become cyanotic, and so there will be a higher affinity for oxygen. So this is like one of the preventive mechanism, or body will start kind of increasing the hemoglobin level to improve the overall oxygen saturations. But there are gradually they go into polycythemic phase, and then they go into
Hmm.
multiple problem regarding the higher hemoglobin, and then they will have a problem with their development later on, and then they will have a coagulopathy because of the component of RBC was higher compared to the functional factors and platelet. So I think
Hmm.
these are their normal natural history if they goes with unrepaired, but they live along because there is not much,
Yeah,
and then gradually they become less active, so they
that's actually,
reserve a lot
yeah.
of energy. But by
Yes.
this, I think gradually they keep on living without any repair.
Yes, he used to crawl. He used to crawl. That
Right.
child used to,
Yeah.
in the end, started crawling. I
Mhm.
remember that. But still, we Nair Hospital and maintained him in the Ward 15. He was there
Mhm.
that way. And another thing I remember, after doing the BT shunt, we didn't have that time ultrasound or anything. I what we used to do on the before extubation of the child, on the
Remember.
tube itself, we used to hear the murmur. If
Yes,
the that is all, that is why then we used to say, oh, BT shunt is successful.
yes, yes. But madam,
Because,
I am still remembering that when we are performing BTs, and even now also, after completion of BTs, and suppose we are doing off-pump BTs, and we still listen, put a stethoscope on endotracheal tube to listen the murmur, because surgeon is performing till the surgery, and we cannot place any stethoscope there to know the, especially for neonatal BTs, and it is still a very, very much contributing factor of how the shunt is flowing. So we still
okay,
a bell of a stethoscope on endotracheal tube and see hear the murmur, and tell the surgeon that shunt is working well. You can go ahead and complete the surgery.
okay. So that's a good to know.
Yes,
Still
yeah.
it is working. And secondly, we used to be very fanatic about small air bubbles. Do you? It's a still this thing.
Yes, yes, madam. I
Huh?
am also very much in ICU because I work in ICU also now. So
Yeah,
seeing the nursing staff not giving the injection or not aspirating very little fluid
yeah.
before giving, I used to be really shout a lot, because even the smallest air bubble, if reaching to the brain
Yes.
or in coronary, you'll have either cardiac event or CNS event, which cannot be pardonable.
Right. And that please tell our resident, because they for a ordinary case also, no, they are not careful. Means see, I don't come across all of them. Whosoever I'm working, I shout at them, I tell them it is somebody else's life. We should not play like this.
Yes, madam. So
For a,
whenever,
even yeah, even for a simple case, you should aspirate and then no air bubble we should push inside.
yes, madam. Those who are coming with me and cardiac anesthesia, the first thing definitely that cardiac, we are very finicky about air bubble, either in
Yes.
bypass circuit or our side circuit, either in infusions. We cannot tolerate even a smallest air bubble in arterial line and all these things. We have seen problem regarding this.
Yeah.
It is
Yes.
not, though it is looking very irrelevant of saying that please aspirate, but it is having a huge impact on overall outcome.
Outcome. Yes. Yes.
Dr. I wanted to ask you, your supports which you prepare for these in the pediatric age group, are they prepared in dextrose or normal saline?
So
Oh, that's very important.
inside the theater, we are preparing in normal saline, because what I have seen is during the surgery, even we are not giving any dextrose containing saline throughout the surgery, because of so the surgical stress is so much, and the inotropic also is there. They usually have a higher blood sugar level to start with. When we reach to the ICU after PO is 0, I have seen that gradually the higher sugar value will gradually come down to normal on POD 1. from POD1 we start preparing on dextrose, and then dextrose saline will be started in the ICU, not in the OT.
So just to just one sentence as a recap, whether you have a corrected tetralogy or a non-corrected tetralogy coming in for a non-cardiac surgery, if at all you have ruled out that and the patient is coming for non-cardiac, which is an emergent or an emergency surgery, and if the coagulation profile is kind of within normal limits, you are okay to give any regional blocks to this patient if it so warrants?
That depends on what I feel. It is personally, maybe some of the doctor may not agree with that. But what I feel is, if it is cyanotic, not to give regional, because even though your coagulation profile is normal, there will be a platelet dysfunction. We are only measuring platelet count, but genuinely the platelet which is there also is not normally functioning. So these are the patients will have a higher tendency for bleeding and all. So what I prefer, if it is cyanotic, better to avoid regional. Regional block is still fine, but like spinal and all this.
Yes, yeah, regional blocks.
Regional block is fine, but otherwise epidural and all, I preferably feel that we should avoid.
And what would your dose be for a caudal or a block? What would your dose be?
So we are using caudal in many of the patients now, because we start extubating on table. So we are using a volume of something around, so if it's 10 kg, we are using volume from 15 to 18 or maximum 20. So 1.5 ml per kg to 2 ml per kg. Wise, and we are not we are using at present clonidine and morphine combination for caudal, only analgesia purpose.
Okay, only clonidine and morphine.
So you don't give any local anesthetic?
No, madam, because we want analgesia, and then we want the effect stays around 12 to 16, 18 hours. Single shot caudal we are using for this kind of patient.
Interesting. Okay.
You should try.
And if at all we require to use it for some surgical purpose, then what would your dose be for any local anesthetic?
Madam, I don't have experience of how we are not doing it. So
Actually, you are using it only for analgesia purpose.
Yes.
But if it is a cardiac patient with a lower abdominal surgery or an anal surgery, I mean, I have given a caudal block on first and second day.
Yes,
Just single shot caudal block, because with that you avoid inhalation anesthetics, and you can induce with ketamine and just give oxygen and then give a caudal block, and anoplasty or things like can be easily carried out.
Madam, what would your dose be for your local anesthetic in such patients?
The same as 1 ml per kg.
Okay.
If it is, of course, premature baby, 0.2% bupivacaine, and a normal weight baby, 3.5 kg, 1 ml per kg. If it is only perineal work, then 0.75 is also enough, 0.75 ml per kg.
Is that Armitage formula, na? For caudal, we follow the Armitage formula.
Armitage formula.
Okay.
It was really very interesting. I have enjoyed thoroughly, right from yesterday's also, today also. Thank you so much. Thank you.
Thank you so much, Dr. Tailor, for taking so much of time for us, and we appreciate all that you taught us today. And I'm sure our residents would also have been, I mean, I'm sure this is going to be an impetus for them to go and read up a bit and be prepared for the exams. Indeed, for that.
And one just little personal question in the sense, how do you relax? This must be so much tension filled of this field is inducing these small children with cyanotic and cyanotic, and how do you relax them?
Madam,
you get worked up during procedure. This also our students should know.
It become habit now, because I'm seeing even ICU also. So ICU is also under my care. Though we are working in a team, it is not only one person can do all these things. So anesthesia and ICU will be under me. So I have a team of a doctor and all colleagues are excellent working. It is teamwork. Not only one person can kind of handle workload of anesthesia and ICU.
I think everything is a teamwork.
Yes.
Wherever you work or whatever procedure you do, it's a teamwork.
Right. Okay,
Thank you, doctor. Lovely lecture.
so much.
Thanks a
Thank
lot.
you so much once again
Thank
for
you, madam.
spending a wonderful 2 days with us,
Yes.
evenings with us, and really good. Thank you so much. Really.
Thank you,
Thank you. God bless you. Huh? God
madam.
bless you.
Thank you.
Madam.
Okay,
Thank
madam.
you for giving
So
up.
bye bye. Bye, Kalpana.
Bye.
Bye-bye.
Bye.
Bye. Thank you, madam.
Thanks, Kalpana.
Thank you, sir.
Dr. Taylor. Thanks.
Thank you, sir.
Thank you. Bye-bye.
Thank you, Alka. Bye.
Bye
Bye.
bye, ma'am. Bye.
Bye. Yeah. Bye.